residency training at the University of Michigan Medical Center. Then it was there that he kind of built his interest in the cerebrovascular diseases, and thereafter he went on to do a neuroendovascular fellowship at SUNY Buffalo. He currently serves as the medical director of the neurological surgery department, as well as neuroradiology at UAB. He's active in resident education. He is published many peer-reviewed journals and textbooks, specifically the Handbook of Cerebrovascular Disease and Neuroendovascular Technique. He's active in cutting-edge clinical trials. Hopefully today he gets the chance to speak to some of to us about that in his multi-center clinical studies involving blunt cerebrovascular injury. And with that being said, Dr. Harrigan, we're excited to hear your talk on BCVI.
Thank you, Dr. Peer, and thank you, Dr. McDougall, for the invitation. I'm deeply honored. Shall I share my screen at this point?
Yes, you can.
Okay. I'm looking for the share screen icon. I don't see it.
It's about 4 on the very bottom of your screen. There's
oh, I see it.
Microphone. Okay. Yeah, share screen.
All right. Okay, can you see my slide?
Yes.
Yeah, looks great.
All right, so I'm very honored to be able to present what I consider a passion in my field, blunt cerebrovascular injury. I don't really have anything to disclose. So as Dr. Peer mentioned, I've been at UAB for 2 decades now. I do open vascular and endovascular neurosurgery. And it's I'm fortunate to be in Alabama because, as you can see, we are in the stroke belt. In fact, we consider ourselves the buckle of the stroke belt. It's like drinking from a fire hydrant. As of yesterday, we had done 1 thrombectomy for stroke a day through the month of May 2024. So we're very busy. And if you glance up in the northwest corner, you'll see that King County has a very low incidence of stroke mortality compared to the stroke belt. In any case, I want to begin by acknowledging my numerous collaborators, only some of whom are mentioned on this slide. I've had the opportunity to work with people both at UAB and other centers on BCVI. But my main man is Jan Janssen. He is a former British paratrooper, now a trauma surgeon at UAB, who has expertise in Bayesian trial design, and he is well-positioned, well-connected, and well-respected in the trauma surgery community. So a lot of the stuff that I'm going to present today is a result of my collaboration with this individual, who I have a great deal of respect for. The best thing about working with Dr. Janssen is that when we do Zoom meetings together, his British accent sort of elevates the tone of the meeting. Now, Corey, I have about 200 slides. I understand I'm allowed to speak for about 3 hours. Is that right?
Yes.
No, okay. I'm just kidding. All right, so let's consider this case. This is a 35-year-old man who came into the UAB ED on a Saturday morning after a motor vehicle crash. He had polytrauma, traumatic brain injury. He had atlanto-occipital dissociation, small subdural hematoma, multiple long bone fractures, also a left hemiparesis. Next CTA showed a dissection involving the right cervical internal carotid artery. And here's a CT perfusion showing a core in the right parietal lobe. We did an angiogram, this is some time ago, and we saw a pretty lurid appearing dissection involving the upper cervical and petrous segments of the internal carotid artery with thrombus in it. And then on the lateral view, you can see an abrupt occlusion of the angular artery that corresponds to what turned out to be his ischemic stroke in the right parietal lobe. Now, I submit that management of this particular case of BCVI is pretty easy because there's not a lot we can do. You know, we can't stent because he can't have dual antiplatelets because he has polytrauma and needs other surgeries. We gave him an aspirin and just hoped that that would do him some good without any real data to support that. Now, here's another case of a lady, 43-year-old woman who had a traumatic dissection, but not polytrauma. She had right hemispheric ischemia due to a complete occlusion of the right internal carotid artery. So we were able to do her a lot of good in the angio suite. We were able to get into the true lumen of the internal carotid artery using intravascular ultrasound. and reconstructed her internal carotid artery using telescoping pipeline stents after loading with dual antiplatelet therapy. She came out of it with a fairly modest racing stripe type stroke and made a wonderful recovery. 5 months later, she was almost completely intact, except for some apraxia in her right upper extremity. But those are the easy cases, I submit. What are the hard cases? It's these kind of cases, the asymptomatic patients with blunt cerebrovascular injury. So on the left, you see a complete occlusion of the left vertebral artery. The right panel, you see a filling defect in the left internal carotid artery. So, what do you do with these patients? You found that they have some sort of an injury, BCVI, of the extracranial arteries or skull base arteries. What's the best way to prevent a stroke? What is the risk of stroke? What kind of strokes can they have? Do they need a catheter angiogram? So these are the interesting questions I've been able to pursue over the years. My own interest in this disease began nearly 2 decades ago at the Jackson Hole Conference. So the Jackson Hole Conference is an annual summer meeting that's very unique because it's basically a global morbidity and mortality conference where people present cases, several vascular cases that had a bad outcome. And the whole point is for people to learn from them. So my interest in this disease was inspired by a case from another center that the operators took care of a patient with an asymptomatic mid-cervical vertebral artery traumatic aneurysm. They injected onyx. Onyx embolized to the basilar artery, and the patient had a brainstem stroke. And so I remember just standing up at the meeting and just simply asking him to really understand the natural history of blunt traumatic aneurysms. Do we really know what the optimal treatment paradigm is? And so I began reading. And so what I'm going to say about the trauma surgery community in the next few minutes comes from deep respect for that discipline. I have a lot of friends who are trauma surgeons and everything, but in the mid-2000s, I came across papers with sensational titles like The Unrecognized Epidemic of Blunt Carotid Artery Injuries, Devastating Potential of Blunt Vertebral Artery Injuries, Devastating Consequences of Pseudoaneurysms. And then on the paper on the right, the authors proclaim that anticoagulation is the gold standard therapy for blunt carotid injuries to reduce stroke rate. Now, this literature that began in the 1990s and these papers extended to the mid-2000s are observational studies. And the authors didn't have the benefit of neurologic expertise. They weren't able really to distinguish strokes on arrival from strokes that develop later or approach the ischemic strokes with any degree of nuance or sophistication. And so that's why I have been very interested in collaborating with the trauma community over the last decade and a half to really home in and find out what's going on. So beginning around 2010, we did a series of about 120 catheter cerebral angiograms in all patients with a neck CTA that was read as showing evidence of BCVI. We've done an array of observational studies. We used optical coherence tomography to study blunt traumatic aneurysms. We did an in-depth analysis of strokes based on MRI analysis and other studies. And I've been fortunate to collaborate with UAB stroke neurologists and also the trauma surgeons at UAB. And then for the last half decade or so, Dr. Jansen and I have been attempting to design a randomized controlled trial to produce the very first class 1 medical evidence in this disease. And it's been very challenging. So what is blunt cerebrovascular injury? This is extracranial skull base carotid vertebral artery injury that occurs from high energy trauma, from stretching of the artery mostly. It occurs in around 5 or 6 or 7% of all blunt trauma admissions. And importantly, it's useful to note that blunt trauma patients can have a hypercoagulable state that can last hours or even a day or two after the original injury. This may be an adaptive evolutionary trait to minimize blood loss after trauma. The pattern of injury can vary widely. You can have a minor intimal disruption, which exposes circulating elements, clotting elements to subendothelial molecules, causing a blood clot to form that can embolize and cause an ischemic stroke. You can have disruption of the elastic lamina and formation of a traumatic aneurysm. You can have an intramural thrombus, which can reduce flow through the artery and cause ischemia that way. So I'm going to step back for just a moment and draw a distinction between spontaneous and traumatic arterial dissections. So there's a lot of literature about spontaneous dissections. These often involve no trauma or low energy trauma. That might comprise extending the neck at the beauty parlor, or coughing, or scuba diving, or golfing. That's low energy trauma associated artery dissections, usually diagnosed after pain or Horner syndrome or some other neurologic problem occurs. And it's strongly associated with connective tissue disorders. Greater than 50% of people with spontaneous dissections have disordered collagen fibers on electron microscopy. In contrast, most traumatic BCVI lesions are clinically silent and found by screening CTA. Ischemic stroke tends to occur early on. We'll talk about the timing of that shortly. And they often occur in patients with polytrauma, which makes using blood thinners to prevent thromboembolic stroke problematic. And then other sources of neurologic problems. They can have a subdural hematoma. They can have a traumatic brain injury that makes recognizing an ischemic stroke due to BCVI very difficult. Then, as I mentioned, these patients can have a hypercoagulable state that can contribute to the risk of thrombus formation. So we did a study about 11 years ago where we drilled in very closely to the pattern of stroke in patients with stroke due to BCVI and MRI. And we found that the majority of strokes had a thromboembolic pattern. We confirmed this by using Doppler to look for microemboli. A certain percentage also had microemboli. And it's also been established by us and other centers that most strokes occur within 72 hours of the injury. And that's the highest risk period, obviously. And that's contributed to our current paradigm at UAB for observation that I'll discuss later in the talk. So importantly, there are two kinds of BCVI, basically. There is BCVI lesions with ischemic stroke that occurs, the stroke occurs prior to admission or prior to diagnosis, like after admission to the ED, but before the CTA shows the BCVI. And this actually comprises a pretty hefty proportion of BCVI-related strokes. From a third to more than 2/3 of strokes can occur prior to diagnosis of the lesion. And that's supported by a study that we published 2 years ago. In contrast, asymptomatic BCVI found by screening ex-CTA is the minority of patients with stroke due to BCVI. And those are the patients that we're going to focus on in terms of like trying to prevent a stroke. Now, Walter Biffle is a trauma surgeon, used to be at the University of Colorado. I think he's in San Diego now. He deserves credit for establishing this classification scheme for BCVI lesions based on their appearance on catheter angiograms back in the 1990s. So this is well established. This is a vocabulary, if you will, for discussing these kinds of lesions. So so-called Biffle type 1 is minimal intimal injury or some irregularity with less than 25% narrowing of the caliber of the artery. Most frequent lesions seen, a stroke rate in the neighborhood of 3 or 5%. These are stroke rates with initially asymptomatic BCVI treated with antithrombotics. Biffle type 2 lesions are a dissection with a raised intimal flap or narrowing of at least or greater than 25% or intraluminal thrombus. This is a little less common than type 1. Also, as far as we can discern, associated with a fairly low chance of stroke in the neighborhood of 3 to 5% for both the carotid vertebral systems. So-called type 3 Biffle lesions are traumatic aneurysms that we'll focus in on shortly. They comprise about roughly 10% of all BCVI. The type 4 lesions are the most dangerous in terms of risk of stroke. So with a complete occlusion of the internal carotid artery, unilateral occlusion of the carotid artery, that carries about a 30% chance of stroke based on our studies, and unilateral vertebral artery occlusion in the neighborhood of 15 to 20%. Bilateral vert occlusions carry a higher risk of stroke, but they're so uncommon that we don't have really good data on them. And then the so-called Biffle 5s are transection of the arteries, the least frequent of all patterns, probably because a lot of those people don't survive very long. So it's fortunate that the most dangerous pattern of injury are the relatively uncommon ones, the type 4 occlusion, complete occlusion or thrombosis of the artery. So next CTA. Next CTA is easy, it's convenient. The trauma surgeons at UAB plug patients in to the ED CT scanner to get their next CTA along with other scans. Interestingly, the next CTA false positive rate is about 50%. And this is from a paper by Ramesh Grandi, who's an endovascular neurosurgeon at Utah. And this fits with what you would expect because radiologists want to overcall, right? They want to say possible BCVI or subtle caliber change consistent with possible BCVI. And, we vascular people, cerebrovascular people, with a lot of experience, can fairly straightforwardly distinguish convincing BCVI findings on an XCTA from questionable ones at most. So we're talking about a complete occlusion, or as you can see, these two examples, there's a filling defect that's obvious thrombus in the artery lumen itself. And so those are true positives and probably reflect a real risk of ischemic stroke, thromboembolic stroke. Now, which patients should be screened with next CTA? Both the Memphis Trauma Surgery Group and the University of Colorado Trauma Groups came up with a set of what they established as risk factors for BCVI. This includes cervical spine fracture, head injury, skull fractures, facial fractures, seatbelt sign, which is a bruise across the neck, Horner syndrome, neurologic deficit not otherwise explained. So this led to the widely recognized so-called Memphis criteria and Colorado criteria, or Denver criteria. So it turns out that about 1/5 of all blunt trauma patients who are admitted through the ED have one of these BCVI risk factors. If you do screening CTAs in patients with one of those risk factors, then about 10% of them will be positive for evidence of BCVI. But the drawback to selective screening is that using these criteria, you're going to miss about 80% of BCVI. I'm sorry, identify 80%, but miss up to 20%. And so at UAB, we adopted a so-called universal screening protocol back in 2016 when a young man after a car crash had a stroke, and he turned out to have a pretty nasty looking right internal carotid artery injury, but he didn't have one of the risk factors for BCVI. So he didn't get his screening CTA. So based on that one case, the trauma surgeons began doing next CTAs in all trauma patients admitted with blunt traumatic injury. And we recently published a study of those, and it turned out that with a so-called universal screening protocol, 7.6% of all blunt trauma admissions have CTA evidence of BCVI. So let's step aside and just consider a special subset, traumatic aneurysms. So as I said, these comprise about 10% of BCVI injury patterns. These lesions represent a defect in the elastic lamina, allowing the adventitia to bulge out. And so we did a study with optical coherence tomography. The panel with the loops toward the right shows the angiogram, and you can actually see the Dragonfly OCT catheter in position. And we got a super high precision look at the artery components. And so what we found was that the intima was torn up and ripped up all over the place. We also found that the elastic lamina was disrupted, as you would expect, in the region of the aneurysm. But we also found that the adventitia was intact. So I think these lesions result from a defect in the elastic lamina causing the adventitia to stretch out. And I teach our residents to prefer the term traumatic aneurysm over pseudoaneurysm, which is, in my mind, a completely different kind of lesion. Pseudoaneurysms possess no normal elements of the artery wall, usually are composed of sort of a fibrin cap. And in neurointervention, we're used to seeing those occasionally in patients with femoral artery injuries after puncture of the femoral artery. So in those patients, you can get this giant pseudoaneurysm because there's no adventitia there. So these are traumatic aneurysms. And as I'll show, the vast majority are benign. So we did a natural history study, I think about 25 or so patients with blunt traumatic extracranial aneurysms. And we found that the majority of them are less than 10 millimeters in maximum dimension, and the majority of them never change. And so This is the maximum dimension on initial imaging versus last imaging, I think 18 months later. We subdivided them into saccular and fusiform shapes, and only 3 of all of these aneurysms, which were all saccular, increased significantly in size over time. So we seldom endovascularly treat these kind of lesions unless they're greater than 10 millimeters or causing symptoms somehow, or are demonstrating significant enlargement on follow-up imaging. All right, so we know that most strokes, not all, but most strokes from BCVI are caused by a thromboembolic mechanism. So it seems logical to use some sort of antithrombotic strategy to prevent strokes in patients with initially asymptomatic BCVI lesions. So you can take your pick. Broadly speaking, you can choose between anticoagulation, antiplatelet therapy. Anticoagulation historically has been the conventional treatment for arterial dissections, especially ones associated with a large thrombus load. But the primary drawback in this setting is that about a third of trauma patients cannot be treated because of other injuries or the necessity of doing some sort of surgery, orthopedic surgery, or neurosurgery or whatever. Antiplatelet therapy makes intuitive sense because these are artery to artery embolization situations. We know that clots that form in an artery are platelet rich and therefore are classified as white clot. And so it just makes sense to me that, giving antiplatelet agents may be sensible. And then we have a sense that it's low risk. So back in 2011, we did a study, or a survey study rather, when we polled people to see what their preferred antithrombotic strategy was. And back then, some 14, 13 years ago, the majority of respondents said preferred anticoagulation. The discipline has changed over the years. A more recent survey that Jan and I did, we found that 2/3 of clinicians preferred antiplatelets and a minority preferred to use anticoagulation. There are various strategies for using antiplatelets and anticoagulation, but I submit that we simply don't have enough data to allow us to make granular decisions about the kinds of blood thinners to use. So let me mention our current practice. I described our adoption of this universal screening protocol in 2016. For all patients with CTA evidence of BCVI, UAB vascular neurosurgery is consulted, and we'll look at the scan. If we agree with the radiologist that there really is convincing evidence of a BCVI, we'll initiate aspirin in the emergency department. We'll continue it for 90 days. It's generally recognized in the dissection community that arterial dissections are healed within about 90 days. That's the rationale for that time interval. And then patients with type 4 lesions, complete occlusion, are admitted to the neurosciences ICU for observation for 72 hours. And then we try to see these patients in clinic with the next CTA in 90 days, but even that's problematic for reasons I'll tell you later. And then we reserve catheter angiograms for only cases in which we anticipate doing some sort of endovascular procedure. I mentioned that we did about 120 of these years ago, and the most important lesson we learned that they simply didn't really change management. So before I go on, I forgot to mention in the slide where I was distinguishing spontaneous dissections with traumatic dissections, unlike in the BCVI world, there is some pretty good data to guide management of patients with spontaneous dissections. So in the United Kingdom, a few years ago, Hugh Marcus, who's a British vascular neurologist, and colleagues published a trial called CADIS, CADISS. They took people with spontaneous or low energy arterial dissections that were symptomatic. Patients were randomized to either anticoagulation or antiplatelet agents. It was a pragmatic trial because the individual centers were allowed to select their regimen for antiplatelets or anticoagulation. And that was a 250 patient randomized trial. That was interesting because the stroke rate was very similar and very low in both groups. About 2%, I think, at 90 days. There have been 2 other randomized trials that I'm aware of that have been published for antithrombotic treatment of spontaneous dissections, but we don't have any of that for BCVI. And I actually contacted Dr. Marcus to clarify that they did not include high energy traumatic dissections in the CADIS trial, and he confirmed that they did not. All right, so there is evidence that antithrombotics may not provide net benefit. So at Houston, UT Houston, the trauma surgeons did a very interesting study, retrospective study of 323 patients with BCVI based on CTA. And 111 patients received antithrombotics, but 212 did not because of polytrauma, multiple leg bone fractures or whatever. And the incidence of stroke in both groups was identical, 9.9%. And then at UAB, we did a study where we found that the use of aspirin in these patients is associated with significantly higher risk of having to give platelet transfusion. I'm sorry, a packed red blood transfusion. So there is a cost in terms of a higher risk of transfusion, and we really don't know if this is beneficial. I mentioned that at UAB we begin aspirin in the ED. We have buy-in among all the services that take care of trauma patients. So we have buy-in to do that from the trauma surgeons, from the neurosurgeons, from the orthopedic surgeons. Interestingly, on occasion, a neurosurgeon will say to me, hey, I have to do a craniotomy for a subdural in this patient. I really don't want to give aspirin. And my response is always the same. I can't tell you that's wrong. So if you want to hold aspirin to do a craniotomy, that's fine with me. I can't tell you that that's wrong. We do know that giving low-dose aspirin is relatively safe in head injury. There have been a couple of publications from other centers that showed that patients with traumatic brain injury and brain contusions seem to tolerate aspirin relatively well without catastrophic hemorrhage. But there is a lot of dogma in this field to use a blood thinner without a lot of convincing data. So in addition, there are wide disparities in BCVI management. And this is just a brief sampling of different regimens. You heard what we do at UAB. At Memphis, they prefer to do a catheter angiogram in all patients, according to Adam Arthur. And then if positive, use a so-called low-intensity anticoagulation regimen. We actually published a letter to the editor about one of their papers. I collaborated with a hematologist at UAB, and we estimated that with the so-called low-dose or low-intensity heparin regimen, some 87% of the patients don't receive any anticoagulation benefit from the heparin at all. So, I think it's probably a sham treatment. Other centers are reluctant to give any sort of blood thinners. At one center, the operators preferred to put a patient on anticoagulation for life. And then the panel on the lower right is one page of a 3-page algorithm for the management of BCVI and blood thinners from a center I won't name. Incredibly baroque, very granular and nuanced, but I submit that we simply don't have the data to allow us to make decisions like that on that low a molecular level. So the trauma surgery community has sort of worked in a silo for a number of years. And I say that, as I said, out of respect for that discipline. I have many friends among the trauma surgery community, but it's sort of exemplified by this relatively recent paper published 3 years ago. This is a multi-center, retrospective, observational study with the acronym PROVE IT. They looked at 971 patients with BCVI, 7% had a stroke. They found that antithrombotic treatment was associated with lower stroke and mortality. And in their abstract, they conclude that, quote, non-treatment with antithrombotics may no longer be a viable option. But the interesting things about this paper is that stroke was never defined. They never distinguished imaging-only stroke from symptomatic stroke. They did not distinguish between strokes on admission from strokes that occurred later after admission. And interestingly, the paper has 46 authors, and they're all trauma surgeons or trauma nurses. Frankly, if I became interested in heart attacks that occurred after ruptured aneurysms, I'd naturally work with a cardiologist. So the trauma surgery has sort of been isolated from the neuroscience community. And I say that, as I said, with respect. I count one of the authors on this screen as one of my good friends here in Birmingham. And that's why I've been excited to collaborate with Dr. Jansen to organize a trial to sort of bring together both groups. This is just a study we did that illustrates the silo phenomenon. So the red circles are neurosurgery publications about BCVI. The blue circles are trauma publications about BCVI, and the lines represent referencing of the other papers. So you see the large blue circles, they represent kind of the founder effect of the field. You know, Dr. Biffle's early publications in the 1990s are referenced by everybody. But you'll note that the trauma publications reference each other, but rarely the neurosurgery publications. Neurosurgery publications often reference the trauma publications. It's just an illustration of societal behavior that we're trying to break down and move beyond with collaboration. So Dr. Jansen and I and Joshua Richmond, a biostatistician here at UAB, have collaborated for the last half decade or so with StrokeNet. So if you're not familiar with StrokeNet, this is an NIH-sponsored 27-center network that is tasked with developing and executing randomized trials in the cerebrovascular sphere. So with a great deal of help from StrokeNet in terms of feedback and study design and statistical help and budget making efforts, we were able to draft a pretty, what we thought was sophisticated proposal for a phase 2 randomized trial in this space. So the key questions: does aspirin, the most widely used drug, reduce the number of thromboembolic events in trauma patients with BCVI? And is it even possible to conduct a randomized trial without causing harm? So we wanted to gather data about safety, feasibility, and informed design of a definitive trial. And this is a trial of placebo versus aspirin. Now, in preparation for this proposal for a trial, we did a study at UAB of 20 blunt trauma patients with screening CTA evidence of BCVI. None of the patients had evidence of clinical stroke on admission. They're all given aspirin 81 milligrams a day daily. And we found that brain MRI scan done about a week after the injury, 43% of the brain territories corresponding to the injured arteries had ischemic lesions on diffusion-weighted imaging despite the aspirin. And these were ranged in number from 2 to 25. And as you can see on the MRI cuts, they had a thromboembolic pattern. So we proposed the first randomized controlled trial of stroke prevention in trauma patients with BCVI with a novel endpoint, MRI detected ischemic lesions, which we viewed as serving as a surrogate endpoint for clinical strokes, which is an attractive aspect because, with 43% of vascular territories having ischemic lesions versus, 3-5% or so having clinical stroke, you could substantially reduce the needed sample size for a randomized trial. We also used Dr. Jansen, his experience and expertise in Bayesian trial to design a Bayesian design. We proposed a phase 2 multi-center pilot safety feasibility study with 180 subjects at 14 centers. We envisioned having a phase 2 phase focused on safety and feasibility, and then depending on the results of that, possibly followed by a definitive phase 3 trial. The concept was to assess for eligibility and then randomize to placebo or high-dose aspirin, 325 milligrams, to get an early MRI scan. And that's because we know that a good proportion of ischemic strokes are already present at the time of diagnosis or before admission to the ED. And then we'd give the aspirin, we'd do neuro checks, and then get a follow-up MRI scan at a week or so. And then that would allow us to hopefully detect a biological signal, an advantage of giving the aspirin in terms of MRI ischemic lesions, and then do clinical follow-up at 90 days. We proposed that we include extracranial BCVI diagnosed on next CTA with a history of trauma within 24 hours, and that the subject could be enrolled, given the study drug, and undergo brain MRI scan within 24 hours of the injury. The patient had to have an anticipated stay of at least 7 days, no known baseline antiplatelet or anticoagulation use, age at least 15, because a lot of trauma patients are teenagers, Exclusion criteria included clinical suspicion of stroke, because that would confound the recognition of a new stroke due to BCVI, patients that are devastated and not expected to survive very long, patients with spinal cord injury or other traumatic injuries producing a focal neurologic deficit. And then importantly, we wanted to include patients with moderate and mild traumatic brain injury to make the findings of this trial generalizable. So we propose to exclude people with severe traumatic brain injury because it's hard to recognize clinical stroke in those patients. But we wanted to definitely include other patients with traumatic brain injury. Of course, contraindication to aspirin and MRI, craniotomy anticipated, and other subgroups. So our outcomes considered MRI detected ischemic lesions to be the proposed primary endpoint for a later phase 3 trial, and to look at numerous other outcome endpoints that focus on safety, feasibility, and could provide baseline data for a possible later third phase 3 trial. So potential outcomes, aspirin conclusively effective, no further trial, aspirin conclusively harmful, no further trial, and then possible benefit or possible signal, as they say, possibly followed by a phase 3 trial. So Jan and I actually had a series of Zoom meetings over the course of about a couple of years. And it was an interesting experience because at each center, we met with people with expertise in stroke and also people who were trauma surgeons with expertise in BCVI. And it was interesting because we actually did get buy-in for a placebo versus aspirin randomized trial. At a couple of centers, there's a little bit of skepticism. There's 2 centers specifically that said flat out, no, we don't think that that's okay. But at the other centers, they were open to it. And the scheme of the study was to, at each site enrolling patients, we were going to have a neuroscience co-PI with some expertise in stroke, and then a trauma surgery co-PI. And that would allow collaboration. But in my mind, even more importantly, it would allow us to, once we finish the trial, to convince both the stroke community and the trauma surgery community that these are actionable results, that they can use these results to take care of patients. Do you remember the Aruba trial, J.P. Moore, the stroke neurologist at Columbia? So the Aruba trial was a randomized trial of treatment versus no treatment for unruptured brain AVMs that was highly controversial. Even during the trial, when we're enrolling patients in that trial, there were neurosurgeons that were writing editorials against the trial. And so when it was completed and published, there was a lot of reluctance to adopt the results. I think the trial was actually did some good. It changed practice in a positive way by reducing sort of willy-nilly embolization of brain AVMs. But it's an object lesson in not sort of embracing your target audience, your target discipline and community before you even do the trial. So that Aruba trial experience weighed heavily in my mind as I worked with Jan to, as I said, work closely with the trauma community to come up with this prospective randomized trial. So our application for a randomized trial was supported by StrokeNet and went to study section in April of 2022. The result was no score, which is disappointing. You basically can get either a high score, which is good. I'm sorry, a low score, which is good, a high score, which is not as good, or no score. We got no score. But we did get 21 pages of helpful comments from the reviewers, and so I'm grateful for that. And we had a series of meetings after that with StrokeNet leadership, and Scott Janis, the program director for NIMDS, Joe Broderick, the PI for StrokeNet, and Mark Chimowitz, who is the chair of the Prevention Stroke Working Group. And they sincerely endorsed an effort at a redesign and reapplication. They gave us a couple of years off to sort of go back to the drawing board and rethink things. We're currently doing another study of MRI detected ischemic lesions at BCVI and try to come up with a better way to do this trial. There are significant barriers to a randomized trial in this space. Actually detecting a clinical benefit with any antithrombotic strategy is probably impossible in these patients who are typically saddled with numerous injuries, confounding injuries, and as I said, detecting an actual clinical benefit in terms of reducing clinical stroke is probably simply infeasible. And then you have to consider bleeding risk. And trauma patients are notoriously poor at following up. They're often uninsured, indigent. They often go off to a nursing home. Getting them to clinic to follow up is problematic. In our experience, we've only been able to get about a third of BCVI patients to follow up at 90 days in clinic. And then the most daunting aspect to this project to me is that simply there's diminishing interest, I think, in using MRI detected ischemic lesions as a surrogate endpoint for clinical stroke in randomized trials. There have been a handful of randomized trials actually using brain MRI detected ischemic lesions as an endpoint that have not really panned out in showing a benefit or a difference between arms of the trial. And this has been done with carotid stenting, with cardiac valve procedures, with blood thinners for prevention of secondary stroke after atrial fibrillation related stroke. And the sense we got in meeting with the NINDS that in the light of several negative trials using MRI detected ischemic lesions, as attractive as that seemed to us originally, that may not be the way to go. So what have we learned from this? Well, I can tell you that that BCVI-related stroke occurs prior to admission, or at least prior to diagnosis of the BCVI lesion in a significant proportion of patients, maybe a majority of them. Aspirin, although widely used for prevention of stroke, remains unproven. There is no level 1 medical evidence and may never be. Most BCVI extracranial aneurysms do not require stenting. I have friends around the country that still sort of knee-jerk treat every traumatic aneurysm they come across, and I submit that that's not necessary. And lastly, the carotid artery and vertebral injury study, the CAVIS trial, if we ever get it funded, may provide good evidence to guide management. And as I said, I look forward to, if we ever do a trial, to working very closely with both the neuroscience community and the trauma community to pull off the trial. Thank you for your attention.
And thank you again for that great talk. I'm just going to open up the floor for questions from the panelist or anyone attending online.
Actually, yeah, I enjoyed that a lot. I did a lot of trauma in Phoenix over the years, and faced this problem, regularly, and was often sort of relieved that with the polytrauma that we didn't have options, didn't have to make some of the difficult choices. The choices were all removed from you. I want to start though asking about what the pushback for using diffusion hits as an endpoint. I was involved in a couple of trials that did that. One was the neuronitide for the stroke prevention, where we used that as an endpoint in coiling aneurysms. And at the time, I thought it was genius because it was open cerebrovascular surgeons who were able to take a swipe at our endovascular techniques and count all our diffusion hits, and actually were able to show a difference. But the main thing was you could get overwhelmed. If a few patients had large strokes, that sort of overwhelmed things. But to me, that still seems like a really attractive endpoint.
Well, yeah, I'm glad you said that, because we haven't eliminated it yet. We were just asked to go back to the drawing board and understand it better. So one of the back to the drawing board studies we're doing now is to just get a better grasp of brain volume involved, and then find other studies where these ischemic lesions in MRI did show a benefit. So you're referring to one that I didn't even know about that we need to look up. And so we haven't abandoned the idea, but there's just diluted enthusiasm for it in the light of several published trials in the last couple of years that didn't show a difference.
I mean, particularly nice in the trauma patients. I mean, you got your 7-day follow-up, and the fact that they don't show up at 30 days is less of a barrier then. So in the trial I was involved with, it played out nicely. It was a positive result, and led to the phase 3 trial. So
Yeah, I'm glad you
Okay.
mentioned that, Cameron. I'm going to look it up, and yeah, it's inspiring. So, no, we definitely have not abandoned it, and we just need to uh, approach it more sophisticatedly. One of the things that we decided to do if we make a reapplication is abandon the 90-day follow-up because of the difficulty in getting people to come, and change that follow-up MRI from 7 days to 10 days because the average length of stay for BCVI patients at our hospital is 11 days. So, by moving it out a little bit more, we may capture more ischemic lesions and not try to do the 90-day follow-up because it's infeasible.
I mean, a couple other great points you made in there is that, the risk period is that first 3 days. And, the critical sort of 72-hour window when people are really at risk and you get over that hump and it seems to drop off a lot in terms of the risk. I think another reason why, maybe, of course, you'd like to have the 30-day, 90-day follow-up, but in terms of practical terms, if you can answer the question about what to do in the first 3 days, everybody can manage it after the, all the orthopedic injuries are fixed and everything, then it becomes a lot easier. It's what do we do in these first 3 days? And the other point I really appreciate you making was the sham treatment of the low dose heparin.
Yeah.
I mean, it's just always confused me. You say the treatment is anticoagulation, and so then you say, okay, well, we'll anticoagulate, but not today, next Wednesday. you know, so that's glad you called that out. What were some of the other criticisms in this trial? Because again, the trial to me that you posed looks doable, practical. I'm surprised there was less enthusiasm for it because it has been a real persistent question.
Well, so, in working with StrokeNet, the StrokeNet vascular neurologists, which dominate that organization, once they sort of learned about it from us, they became really engaged. And I think the study section was probably comprised of vascular neurologists and wet lab researchers who have trouble recognizing this as something that needs to be worked out. It's one of the things I like to point out is that, trauma is endemic in the developing world. So, on a global scale, BCVI is probably a major stroke risk, major cause of stroke, especially in young people. So, if we can do a trial and then generalize this and scale it on a global scale, we can move the needle when it comes to stroke and BCVI.
I think it says something about us. Those papers you showed with the epidemic of blunt injury.
Oh, yeah.
I mean, that's when CTA became ubiquitous, right? I mean, and we all sort of went through that, and all these things we hadn't seen before had been blissfully ignorant of. Suddenly we were seeing them everywhere, and really had a little bit of panic about what to do about them. And I think a lot of stents, went in that didn't need to go in.
Yeah, it's funny. There's one group I won't name the center that was already decided. They had already decided they're wedded to anticoagulation, and then they thought they'd try some carotid stents for carotid dissections, but they didn't use dual antiplatelet therapy, and they had thrombosis of a high proportion of the stents. And yeah, it's just kind of crazy. But yeah, we've come a long way, both us and the trauma community in the last 2 decades.
And the other really useful thing that you highlighted here was the pseudoaneurysms, just how benign they are. Again, something that took me a long time to figure out. That very few of those progressed, very few of them needed to be treated. Yeah.
Do you mind speaking to, I guess, the indications in your center for some of the catheter angiograms, as well as those that will go on to treatment for those that are online?
Yeah, so we very seldom ever do catheter angiograms anymore in BCVI patients. As I said, when we anticipate treating something with a stent or a thrombectomy, that's just about it. By the way, back to this traumatic aneurysm issue, I've never seen one that's symptomatic, and the only one I've encountered that was ruptured was from a case report from Japan. So, I can say confidently that we really don't need to treat a lot of these. But yeah, we very seldom ever do angiograms anymore.
Yeah, I'd spent a few years putting stents in them when they were identified, and usually they were coming with TIAs or something. Maybe they had thrombus or something. and put a few stents in, and then I realized I'd never been called to the ED for a emergently ruptured pseudoaneurysm in the neck, and I go, why, where I guess they're all dying in the street, where why have I never seen this?
That's funny.
The penny finally dropped.
Yeah, Dr. McDougall and I have both been around for several decades, so we've had the opportunity to witness the evolution of all kinds of parts of our field.
Yeah, it's kind of fun to sort of see that and see how things we thought and see it evolve.
Are you incorporating transcranial Dopplers as well as part of your flow dynamic evaluation for the repeat patients, or?
No, we don't have the personnel for that here, so we've thought about it, but we haven't done it.
All right. Well, I really appreciate your talk. It's always inspiring to see somebody tackling these difficult problems in a systematic way. I admit that I was much more intuitive at it as the years went along, and not certainly didn't get it all right all the time. So it's really nice to see somebody getting the data and bringing that to us. It's a real service, and I really appreciate it. And enjoyed your talk this morning. Thanks so much.
Well, thank you. It's my little corner of the cerebrovascular universe, and it's very refreshing and inspiring to be able to present to you folks and see so much interest. So, and get your comments, Cameron. I really appreciate it.
Yeah, well, good luck with it getting it up and going again, and thanks again for being here
All
this
right.
morning.
Thank you. All right. Have a good day.
Thanks again, Dr. Harrigan.
Bye-bye.